Everything's good.
You're on YouTube. You're on Facebook.
We're live?
Yeah.
Oh, okay. Thanks for letting me know we're live.
You're live there.
Hello, everybody. Welcome to a chaotic initiation to a very special episode of Fertility Fact or Fiction. I am your host, Dr. Rahi Victory. I am a double board certified reproductive endocrinology and infertility specialist. And we bring you the latest and greatest in the fertility world every week and try and answer lots of questions. This week, we have a very special guest with us, and we're going to bring him on soon. Dr. Fred Dzineku, who is a very dear friend of mine and probably, in my mind, one of the greatest fertility specialists in North America. Brilliant man, very honest, very moral. His wife, Chloe, very similar. And I consider them dear colleagues, dear friends, and extraordinarily good people. And exceptional fertility specialist. So Fred has agreed to come on. I've been begging him for ages, and he will be on the show with us very shortly. So we're going to have an opportunity to talk about something he's really passionate about, which is called Fertility Friends Foundation. And Fred really brought FFF to my attention, and I thought it was a phenomenal idea. And so we got engaged as well. But just before we get to that, I will say that I had a great question from a patient today, and we'll probably use it for one of our upcoming shows, which was, does red meat impact men's sperm quality? And I had no idea what the answer to that was. So believe it or not, there's actually a really good meta-analysis review on this. And so I'm going to present that in an upcoming episode. So we'll talk about men's diet in relation to their sperm health, which I think is critical because we've known it's an issue, but I actually learned a little bit by looking at that article because I had no idea what the relationship between red meat and sperm health was. So upcoming episodes. Next week, we also have an amazing episode with several women coming from Mystoria, and we will be sharing their experience, their amazing new platform, and what they're doing with infertility, which in some ways is going to kind of revolutionize the way we help people who are struggling through their journey out. And I've been involved with them, and I'm really proud of the work that they're doing. So that's coming up next week. But for now, with no further ado, my incredibly gracious friend, colleague, and other half of my brain in many ways, Dr. Fred Dzineku. Thank you for joining us, Fred. Welcome to your first ever Fact or Fiction.
Right. Thank you very much for the very kind and very generous introduction. I feel like I have big shoes to fill now that you've spoken about me. It is my first live. I very much feel like a dinosaur. I talk to my kids. I'm like, I'm gonna Instagram someone. Dad, you don't Instagram someone. Oh, okay, why not? So this is a new thing for me. I'm happy to be here. As you've said, I'm happy to be here. Isabelle convinced me. Isabelle Lefebvre, being the executive director of Fertility Friends Foundation, convinced me to join you on this one so that we could discuss Fertility Friends Foundation initially, because we have a very important event coming up. And I think this is as good, if not better, than any other reason to start this new career of mine.
So tell me a little first, just so everyone gets to know you better, because I talk about you on the show literally every week, but you and Chloe both. But tell us just a little bit about you. Like, how long have you been an OBGYN? Where did you do your fertility training? Kind of introduce yourself to everyone so they know you.
So we and I'm saying we because we really are a team at Tripod Fertility, which is our fertility clinic in Toronto. And Chloe, who happens to be the second half of the clinic and also my better half, Chloe and I have been doing the same thing, and we train exactly the same way. So we trained at University of Montreal. We went to McGill Medical School. We trained at University of Montreal in terms of residency. We did our fertility fellowship in Montreal, and we've been doing fertility since, well, I've been doing OBGYN since 2011. And then fertility 2 years later. We've been practicing as tripod fertility since 2016, 2017, essentially. And so we relocated to Toronto in 2016.
And big news, you have a recent opening, right? You have your own IVF clinic now.
For many years, we were using satellite clinics, or we were using labs, and we were a satellite clinic. And last year, after many years of sweat and a build that was excessively difficult, we finally opened our own IVF lab at Tripod. We are extremely happy. We're extremely proud. We have so far incredible results, and it's been good. We've managed to keep living the dream, if you want, and we help
And
our
I can
patients now
say,
in-house.
I can definitely say that considering you started this with no funding, it takes someone very skilled, very brave, and also someone that other people really trust to do that, because without funding, it is harder to run this kind of business. And I started it that way. And I have to say, I knew from day one that you would do it and you would do it well. So, it takes a special kind of clinician to be able to do that, because people trust you. I trust you, and I tell everybody to trust you. And I think people know the character that you and Chloe have, and it shows in the way you work with people, the way you treat people. And that extends to your patients, your staff, us, the people that know you and work with you. So kudos to you guys. Huge congrats for starting the program, and a huge positive vibes for the future of Tripod. I know it's going to just flourish more and more every year. I'm not going to lie, I'm a little jealous that you got to take the Toronto role. I'm here in Windsor, but I do love my Windsor practice, and Fred and I both share the ability to kind of work together through our two clinics, and have done so for many patients. So I think that's been really great for our patients.
And it has been a very pleasant collaboration, I have to say, because Dr. Victory has been an excellent clinician. There's no question about it. We have nothing to, there's not many clinics that we collaborate with. There are some. I'm not going to say that there aren't, but what's important is that we see eye to eye on clinical care, and we do. And sometimes we have disagreements, but it's always good to have a healthy disagreement that can be backed by facts and by experience. So it has been very pleasant. Thank you very much.
Yeah, I mean, I think philosophically, morally, we're all very aligned, the three of us. So I think that's been huge for us to be able to work together and help patients out. Tell me about the phenomenal Fertility Friends Foundation, and tell me let's tell everybody what it is, and then tell us how it got started in your involvement.
So Fertility Friends Foundation is a charity that has been started. I may not be doing this in the right order, I'm not sure, but it's been started by Chloe, and myself mostly, but also with the help of Isabelle, our executive director. And the idea behind Fertility Friends Foundation is to help alleviate the financial burden that is associated with fertility treatment, and to make fertility care more accessible, more universally accessible. And so we started this in Ontario. It is now pan-Canadian. We're very proud to say that. And through Fertility Friends Foundation and its inception, which is essentially less than 3 years old, we managed to so far donate close to $250,000. It's
Oh my God.
48 patients that have been helped, some of whom probably would not have been able to continue their fertility journey. Only in 2024, we have so far 4 babies that have been born through grants that have been donated through Fertility Friends Foundation. So it is something that is very important to us. We went into this with the idea that we wanted to help people. When we moved to Ontario, we had just come from Quebec, and it became, for many reasons, it became a very difficult conversation that we were having on a routine basis, which is, how can I pay for this treatment? I can't afford it. And that's why we started it. And so far, it's been doing great. Dr. Victory Reproductive Care, Rahi, you've been a friend of FFF from the beginning. You're one of the first people who supported us. And so for that, I have to thank you. You are one of our partners with the IVF cycle program, where Fertility Friends Foundation donates a certain amount of money to grant recipients, and the fertility clinic will offset the balance, or most of the balance of an IVF cycle. So it's essentially giving away free IVF cycles. And you're also an important partner for our 25 donation in 25 hours fundraiser that is beginning on November 14th. And so that fundraiser is very important. We have a lot of ambassadors. I see you're trying to speak, but I'm going fast, but we have many ambassadors. It is a fundraiser that has the goal of raising $40,000. We have many clinics and many associates, so TFP, for example, because it's not only clinics, but Markham Fertility, VRC, Trio Mississauga, Create, the Fertility Partners, and Tripod Fertility, who have also accepted to do matching gifts, meaning they will match every gift that we receive. It's an important program, and it is starting in 2 days, so stay tuned.
Amazing. And I love the fact that you did this so selflessly. I mean, you wouldn't, of course, do it any other way, but a lot of people could have easily set this up to say, we're going to start a charity, but we're going to do it at our clinic. But you actually distribute these funds for people at any clinic, right? Anywhere in Ontario. Like, they don't have to be looking for people that are only going to Tripod.
Absolutely. No, this was important to us. The point of this was to actually make it accessible, and make it accessible to all patients. It has nothing to do with Tripod, and to that extent, we have many partners. So we're really proud at the Fertility Friends Foundation to say that we are partner with Markham Fertility Center, RCC, Create, Trio Mississauga. I don't like naming Twig Fertility. I don't like naming clinics, because then invariably under stress you forget one. So if I forget anybody, I apologize. VRC. But we have partners everywhere, and actually it is now Canadian. So TFP is also partners, and so we have clinics across Canada that we're partnering with, and I think it's becoming bigger and more recognized, and it really is helping people. So we're happy, and the more people join us, the happier we are.
That's incredible. And people can access the application form. Do you want to tell us a little bit about that? Like, how do people apply for the funding? And then tell us how people can support the upcoming event.
So to apply for funding, the application process happens. Well, it used to happen once a year. We're opening it more frequently, but if they go on the Fertility Friends Foundation website, they will see when the next funding round is happening. And we just finished one funding opening, so it's just closed, but there's going to be another one coming up, and so they can apply through the website. With respect to donating, we have, again, through the Fertility Friends Foundation website, through Instagram, through following us, they will see we have regular events. I think the next big event that is happening is the one that's happening in 2 days, where they can, through our ambassadors, donate. They can donate through the website. And essentially, it's important to donate at that point, because every dollar you donate generates a second dollar. So you give $100, VRC or Tripod or any of the other partners will double the money. So this is going to be the next big one, but we have a gala coming up. We have many events that happen throughout the year, and I think it's best read through the website and best followed through the website and through social media.
And tell people a little bit about eligibility, like who can apply for this? How is the decision made to distribute the funds? I mean, you don't need to
Um,
give away any trade secrets or
no,
anything, but
yeah, we have a special algorithm. No, to apply for it, there are many criteria, and you can find them on the website. But essentially, we are trying to make it so that the people who apply have a potential for success. Because unfortunately, we are not yet at the level of Bill Gates Foundation, and so we are trying to target funds where there is a. I'm saying not yet because hopefully Bill is listening and he's going to donate money soon.
huge
Um,
fan of the show. Huge.
right, I'm sure. Who wouldn't be, right? So, but I mean, seriously. So we're not there yet, but essentially, you have to be Canadian. You have to be below 43 years of age. You have to have the collaboration of your clinic because we ask the clinics to give us very basic information, essentially that says, is there a potential or not? In the sense that if you're 62-year-old and you're menopausal and you're trying to do IVF with your own eggs, that's probably not where we're going to allocate funds. Now, this being
Right.
said, I don't know and I don't decide on my own. In fact, I have nothing to do with the decisions. There is a medical committee that is made of different members of different clinics. It is not only Tripod, it's not only VRC, it's not. So any one of our partner clinics who has staff members, physicians, nurses, or others who want to join, or even some members that are not part of clinics can join, and we review the application based on its medical merit, based on its financial needs. Also, we have an algorithm to try to classify, and then we ranked one to whatever it is that we're donating, and that's who gets the grants.
Amazing. I mean, I loved it from day one, and I know you've grown it, and it's kind of uh, taken on a life of its own. And Isabelle is just like the most gracious, dignified, wonderful, beautiful person. She's just so lovely to deal with, and I think the foundation is very, very blessed to have her there, and of course, have you guys at the helm doing this amazing work. I mean, there was nothing like this before you guys started it, right?
I you know there were foundations. I think this is a unique foundation in its capacity to generate this association of many different clinics, and in its
Yeah.
capacity to have people fighting for the same cause, which is patient well-being and patient care. And I think that is very unique. And you're absolutely right. Isabelle is positively brilliant. And Chloe and I on a routine basis, and Chloe really, because Chloe is the one who does 99.9% of the work for the foundation between her and I. It's really her baby, quote unquote. And Chloe and I say this all the time. Without Isabelle, there would be no foundation because she has the capacity to reach out to everybody, and she comes without this oh, it's Tripod or it's VRC. She comes as a foundation, and people open up to her and agree to join. And people are realizing more and more that the foundation is doing this for the well-being of patients, and they could be your patient, they could be my patients. It doesn't matter. At the end of the day, the patients benefit, and we're all happy for that.
Yeah.
So that's what I have to say. 25 donation in 25 hours, starting in 2 days. Please do support us. It means the world to us.
So people should go to fertilityfriendsfoundation.com, correct?
That is correct. And if I'm saying something wrong, I'm sure Isabelle will message me right now, or Chloe will message me. But that is correct. Fertilityfriendsfoundation.com.
Can we, is it possible to put up a link up there? No, because we're on too many platforms right now. Okay. So remember, everybody, fertilityfriendsfoundation.com. Phenomenal foundation. Incredible opportunity to help others who are struggling. If you have anything you can contribute, please help out. VRC helps every year. I think we were there from year one, and we'll be there as long as it continues going and as long as I am able. So yeah, it's an amazing cause. Super honored to be part of that group of people that are contributing to this, and I think people really do benefit from this. So it's been remarkable, and it's so it feels so good to know you're helping so many people in ways that otherwise they wouldn't receive help. So I think that's incredible, and a huge thank you on behalf of all the fertility specialists to you and Chloe, and of course Isabelle and the rest of the team there who came up with this idea, manifested it, and then put it into action. Because without you guys, this wouldn't be there. And I know some other people have tried kind of similar things since then, but this is very unique in that it's not specific to one clinic. And I think that is just an amazing, amazing thing. So yeah, thank you for what you've created. Now, I know you were only here for this, but I may kind of keep you kicking and screaming, handcuffed to the screen, so to speak, because I think people usually ask us questions live. And I would love for you to be on here because we do get interesting questions, and I'd love to see how you tackle some of these. Are you good with staying for a bit?
Absolutely, yes. I'll try to tackle. I don't know if I'll be successful, but I'll definitely try, and I'll try to stay nice and politically correct.
Well, my greatest sorrow about my own multiple personality defects is that I am very bad at keeping a straight face. So sometimes people ask questions, and I have a very hard time keeping control of how I respond. So I've learned over the years to only let my facial expressions say what I want to say. Otherwise, I try and keep it very PC, but we'll see how it goes.
There's fertility after dark.
Oh, is there fertility after dark? So, Fred, fertility after dark is what we refer to when people start asking sexual questions. So we do get some funky stuff that goes on here. So Tarek is on with us, my dear friend Tarek Ibrahim from Ibrahim Strategies Group, and he's got some questions for us. So fire ahead. And Tarek, by the way, Fred, you wouldn't know this, but people call him Dr. T, even though he does not have a medical background. So it's always the people that call him Dr. T that he actually looks through the questions for, because he likes that about it. So yeah, it's a bias. Yeah.
Yeah.
Okay.
I feel good about it, and why not? They deserve it.
All right. What do we have on the docket today?
Okay, so first question.
Yeah.
High T and DV.
Oh, there you go. All right. Yeah, they got us all.
They got us all. That's
Yeah.
right. If you don't need estrogen for lining to get 12 millimeters naturally, do you need it after ovulation? I don't react well to artificial estrogen, but my doc says everyone supplements after OV.
So Fred, I mean, I'm a letrozole user, so we only use estrogen when we need to. What do you do? I think you do a lot of natural cycles, right?
We do, but I didn't understand the question. Is this for a frozen embryo transfer or?
It doesn't actually say, but ostensibly it's probably for a frozen embryo transfer. So if you don't use estrogen in order to thicken the lining, do you
We don't.
supplement with estrogen after they've ovulated?
We do not. We do not. Even the progesterone supplementation is. We've had some cases where patients tell us, "Do I really need it? I don't want to take it." And the reality is that if you do a natural cycle, you have a 28-day cycle. You don't have a luteal phase defect. You have a good lining. You need neither estrogen nor progesterone. And in fact, estrogen is extremely inflammatory. So you're probably better off without estrogen.
This is why I love having Fred on, because and the synergy, right? Because we think the same way. So yeah, I mean, I would agree completely. Like, we don't use estrogen unless we have to. Progesterone we tend to use. There was actually a recent study that said even in completely natural conception, patients did better with Proj, but it was only one study. So we tend to use Proj, but I definitely don't give estrogen, because you're absolutely right. For the exact same reason you mentioned, it is very inflammatory. And if you don't need it, well, why would you take it, right? So, which boggles my mind, because there are so many clinics out there that still use not just a little bit, but like a lot of estrogen in their cycle. And that can be definitely problematic. I was just at a conference in Europe, and at this European conference, they had a very famous fertility specialist there, Greisinger, and he actually laid out the whole reason that people use hormone replacement therapy protocols. And he said basically this was just artificially decided at the dawn of IVF. And no one ever went back and looked at it. And he said now it's very clear we should be migrating to natural or letrozole based cycles, and that Europe is decades behind in this. And I was sitting there going, it's not just Europe that's decades behind. Like North America is still behind in some ways too. So great answer. I'm glad we're totally aligned on that one.
You're right about. There's one thing that is very obvious in medicine, and it's that it's difficult to depart from what we've always done. And so I always tell people basically, well, it's the classic saying, if you always do what you always did, you'll always get what you always got, firstly. But the other thing is that if we are so adamant on doing what we always did, at this point, we should probably be going to work on a horse, because that's what we always did. And it's been proven that there's better ways to do it. So we need to I agree with you. I think we need to slowly drop what is superfluous in terms of supplementation.
Yeah. So for those of you that are watching, by the way, and Fred's a very humble guy. He's probably way too humble because he's a brilliant human being. Fred and his incredibly lovely wife, Chloe, are both reproductive immunology experts. And I think I can easily say Canada's premier reproductive immunology experts, but they're brilliant minds. And so if any of you have reproductive immunology questions, you can feel free to ask those. We can't answer specific questions for your specific case, as you know, but if you have general questions about things, we can tackle those as well. So go ahead, T. What's the next question?
So it's not in order.
Yeah.
It's cherry pick.
Oh, you're cherry picking. Oh, we get burned for that, man. You're killing me. Today's a special day. All right.
Hi, doctors.
Hi, doctors.
So I'm included in that, obviously. Hi, doctors.
Yeah.
Just want to say hello. Been to Tripod myself with Dr. Dzineku, and he is amazing. Power duo here. Love you both. Thank you for all that you do.
Oh, that's sweet.
Well, that's a great question.
Yeah.
Hi, doctors again.
Okay.
So this is the trend here.
Yeah, the trend. Yeah.
I am a KIRAA genotype.
Okay.
Based on fertility testing, and my husband has HLA-C. Okay. Can I only get pregnant with Neupogen? Any suggestions?
Fred, feel free to tackle that one, buddy.
There's a lot of, so it's a long and convoluted question, which I think deserves a little bit more digging into the story. But the idea of Neupogen and KR is that it can be, so you got to differentiate between it will only work with Neupogen, or Neupogen can be beneficial if those are your results in terms of KIR. And so I think the data is not at all telling you can only get pregnant with Neupogen. I think it says, when you've looked at the data, it says, well, okay, the patients who could potentially benefit are the following patient, but it doesn't mean that it's the only way that it's going to happen. So I think that's the long and short. It's funny, we had a patient today who discussed that with us, and it was I think at the base it's actually a patient of Prati Sharma who she had asked us to collaborate on, and that was my answer to them. So we don't really test KIR, to be honest with you. We don't do a whole lot with it. I think immunofertility is a field that is extremely wide. Just as a little bit of a background story, the idea of immunofertility, I don't know if you've mentioned this, Rai, before, but comes from the idea of transplant medicine. So essentially, the idea behind it is that a fetus is a something, an organ or something that you have to accept in your body as a pregnant patient,
Right.
even though it is only at best 50% you and sometimes not at all you. And so the body has to recognize it, say, oh, this is not me, yet I do not have to attack it, just like you have a kidney that is not yours and you don't have to attack it if
Right.
it's a kidney transplant. So that's where the idea comes from. And you can imagine in transplant medicine, there is very many different elements that are looked at in terms of immune system, immune modulation, and preventing rejection, and what causes patient A to reject, whereas patient B doesn't. So at some point, you got to pick your battles. That's not one that we've picked necessarily, but this is nevertheless the answer to the question.
Yeah, and we certainly never tell people anything's 100%, especially when it's reproductive immunology, because we both know, and I think everybody that does this stuff knows that none of this stuff is 100%. It's all based on statistics and odds and chances, and sometimes people have all sorts of immunological problems and they get pregnant naturally, and other times, despite multiple efforts on our on our behalf, that where we're trying things for people, it can be quite challenging. So I never tell anyone you can only get pregnant with this or that. And I think you pointing that out is really very critical, because there's always options, and one of those options is do nothing, and eventually there's a statistical chance it'll still work. So people need to know that there are things we recommend and there are reasons we recommend them, but nothing is ever, sort of ironclad. There's almost always, options and chances with or without treatments.
And I think, Rahia, I'll just add a little something. Dr. T, I know you want to ask another question, but I'll just add a little something that basically, you're totally right. And one of the difficult things as a physician is to say, I'm not going to do anything. And people have to realize that sometimes that is what is called for.
Yeah.
And sometimes too much is like not enough, and you end up being more detrimental by doing
Yeah.
too much. So it is something that we have to keep in mind when we do immunofertility or anything else.
Yeah, hardest thing we do is sit on our hands, right? Like it's so difficult to do, especially when you're raised in a surgical specialty, because we want to do things, right? We want to cut things, fix things, make it different. So I agree with you completely. What's the next question?
Can we, Dr. D?
Oh, you got excluded, dude. I'm so sorry.
Yeah. Slightly wounded.
Yeah.
The question I can answer too. That's the irony of it.
Oh, okay.
That's
Hey,
the killer part.
Fred and I'll sit back, sip our tea.
What are your thoughts on the ERA test?
Oh.
Okay, so that's not a fair question, and I'll tell you why it's not a fair question. Because ever since we've been talking about this, my idea of our first live between Rai and I was to say, let's tackle ERAs. And I think ERAs could be a full episode, if you will, between Rahi and myself. And this is one where we probably disagree, but I'll tell you why we disagree. We disagree because we do mostly natural cycles. And while the ERA initial data was meant to be for natural cycles, all of the data that we have currently that says it doesn't work is really associated to medicated cycles. And so I do think, and we are doing that is it's worth looking at natural cycles in ERAs. And in our experience, all the patients, well, not all the patients, obviously not, but of all the patients that we've done on natural cycles, ERAs have been a fairly successful adjunct. But again, we do mostly natural, we don't do medicated. So with peer pressure, we've had to diminish how many ERAs we do. It's not as predominantly ingrained in our recurrent implantation failure workup, but I really do think there's a role for ERAs in natural cycle, and there's a role for a more theoretically a better developed ERA.
Yeah, I'm gonna say, I mean, we stopped using it a long time ago for a variety of reasons, but I do agree with you, and you make a very valid point, which is the randomized controlled trials were looking at medicated cycles. They were not natural. So I support that. I think that the thing I tell everybody now, and this is really echoing something Richard Scott, who was part of those ERA studies, something he said is, we all know that implantation and the timing of implantation is critical. There's no question. Like, that's incontrovertible. Everybody knows that. The question is, how do we test what those factors, those proteins, those enzymes, whatever it is, how do we test to see how that's optimized? And then the other problem with it is it the same with an embryo there versus not an embryo there? Because obviously when we're doing ERA biopsies, there's no embryo there, or else you'd be terminating the embryo. And the question then becomes, well, how do we know that that lining is reflective of what it would be like with an embryo there? So I think there's something to the idea of the ERA. For me right now, I'm not a believer in that specific test at the moment, but you know what? I have to admit, I have not done it since we switched to letrozole or natural cycles almost exclusively. And so maybe it's worth another look. I mean, Fred, you and I could probably together do the research study that looks at natural cycle ERA and outcomes. I don't think that study exists to the best of my knowledge. Have you seen
It's not. We have retrospective data that we're working on going through, and we have quite enough, so we could probably publish some retrospective data. Moving forward, I think to be prospective, I think it would have to be generalized with.
Yeah, it would be cool to look at prospectively, and that's definitely something we could try. So interesting.
I think you are pointing to a right thing, which is receptivity may not need to be studied with an endometrial biopsy.
Right.
I think we may need to look at it differently. Now, we have the answer for that. I can't give it to you because we're packaging it with the pill for HIV and cancer at the same time. So as soon as it's going to be commercially available, we'll let you know. But no, I mean, really, we do have an idea of other ways to approach the problem, but I think it needs to be developed.
Cool. All right. We dodged a bullet on that one, Fred.
Not sure we did. I'm sure there's a few coming questions.
One failed IVF, untested embryos, switch clinics, PGT done this time. Doc said no downregulation, even if I personally suspect endo because I've had painful periods. Doc still insists that I try no downregulation first with endometrial immunomodulation. Do you think it's fair to try without any suppression first?
To try what? IVF or frozen embryo transfer?
To try a frozen embryo transfer. So she thinks she has endo. She has euploid embryos now, and the doctor is saying no downregulation prior to the embryo transfer.
So I'll tell you what I think, which is, I don't know, in the sense that, do you have 12 embryos or do you have one embryo and it took you 7 IVF cycles to do it? There's a lot to the story, but generally speaking, I don't think it's crazy to try a transfer without downregulation because you think you have endo. Because let's be honest, a lot of people have endo and a lot of people get pregnant spontaneously with endo. So I think afterwards it becomes a question of what do you have? How complicated was it to get to it? Have you been pregnant numerous times, but you've miscarried at 12 weeks, 20 weeks? There's so many other factors, but I just don't think that it's a crazy idea.
Yeah, I mean, I would agree. I think it depends on how many embryos they have, how significant the symptoms are for endo. I am a big believer in a dedicated endo protocol for endo patients, but I also want to verify that they actually have endo, which is often laparoscopy, which, as everybody knows, because I had to tell 100 people today alone, it's impossible to get people into the OR. And none of the current tests that are available for testing endo are that accurate. So I mean, I agree. I think if you have a number of embryos and you're only suspecting endo, I think that's a discussion you have with your doctor, with your partner, with your family, with whoever, to come up with what's a reasonable approach to this. Is it reasonable to downregulate? I certainly don't think it's harmful to downregulate. Is it also reasonable to try? I mean, I think if someone had 5 or 6 euploid embryos and their symptoms were just painful periods, you can't automatically assume they have endo. So yeah, I'd agree with you on that. I think it's worth a discussion, and then kind of decide what you think is best for you. I have to say, downregulation alone, my read of the literature shows that that's useless. So we always mix Lupron with letrozole when we're doing it, but some people still use just downregulation. I haven't seen any studies that support that that's better, but are we dying on batteries?
It's getting low.
It's getting low? All right.
It's not flashing red, but
we're getting there. All right. Okay.
There's still some fun in it.
We had to do a video where we interviewed this wonderful, wonderful surrogate, and we did that before this show. And so the battery on the camera may die on us at some point.
It was way longer than I thought.
Yeah.
That's expect that.
I'll just keep going.
Yeah. So if we suddenly go off camera, we're apologetic, but
the audio will still work.
The audio
so
will
just
still
give all
work.
the questions to Fred. He can handle it.
All right, go.
Okay. Hi, doctors. Question regarding low dose aspirin. 160 milligrams daily at bedtime was prescribed till 36 weeks of pregnancy. I'm over 40, no history of blood pressure. Embryo was transferred in a natural cycle. Should I be concerned about the dose?
So as in because it's too low or too high?
They're not specifying. Yeah, welcome to Fertility Factor Fiction, Fred. Half the time we have to guess what the questioner is asking us. So yeah,
it's called baby aspirin, right?
Yeah.
So no, you shouldn't be concerned that it's. I'm going to assume based on the way the question was formulated that the question is the dose too low? Well, is the dose too high, or is it even necessary because there's no history? I think it's just not detrimental. There's been quite a few studies that have shown that there's a benefit in preventing preeclampsia. It definitely hasn't showed any negative impact that is really worthy of considering. I would keep going.
Yeah, I wouldn't. I agree. And more the guidelines are echoing the value of aspirin especially in older patients. So yeah, I would not change that at all. In fact, I think U of T is now telling everybody who is older, whether it's a natural or an artificially conceived pregnancy, to take 162 milligrams. So yeah, I would not change that.
Chloe and I have a tendency to do that too.
Dr. T concurs with us too. Yeah.
There you go. Right. If Dr. T says it,
then it's gospel, right?
Yeah, it's gospel. Now, I've never seen Dr. T, but I'm assuming he's got a line of hair in the middle of his head like this.
Most of the audience has never seen Dr. T. He's always off camera, so it's quite funny. Yeah.
Hi, everyone. Wondering if Dr. D has encountered any lingering immune issues resulting in multiple failed FETs that have arisen after having long COVID. Thanks.
Oh, that's an interesting one.
No, we haven't. But the reason is simply that generally speaking, we've had very few patients with long COVID. I can think of one person. I don't know about Chloe. I would have to ask her. But really, the reality is that patients with long COVID are probably not pursuing fertility treatment unless it's been resolved at this point. But generally speaking, once you have long COVID, you're not yet at the point of doing fertility treatment. So I have one patient that has, and I don't think there was any immune issues of memory. But no, I don't know.
Yeah, I agree completely. I actually don't think I've had any long COVID patients pursuing fertility. And in fact, I think I've only seen one patient at all who had long COVID. I didn't see, I don't even think we looked at any immune issues, but yeah, it's pretty rare. Good question, though. I haven't been asked that. COVID's kind of fizzled out. I mean, it's not a thing as much anymore. So yeah.
If you don't need estrogen for lining, get to 12 millimeters without support, would you need it after
No,
ovulation?
we did that one.
We
That
did
was
that.
she asked that earlier. That was the first one.
Can use of Lovenox throughout pregnancy increase the risk of hemorrhage during birth?
Well, you should stop Lovenox before you get to deliver, but you give the Lovenox dose that people take in pregnancy is a prophylactic dose, which is incidentally the same dose that you give patients right before you start a hysterectomy or you start a long surgery. So it clearly doesn't increase the risk of bleeding.
Yeah.
But you should stop before for a few different reasons. One of them being that you won't be able to get an epidural. Uh, and then the other one is because you should stop just as a precaution.
Yeah, we always induce those patients, and we induce them knowing that they're on it. So we don't give them their heparin dose the day before the
Okay.
induction, to avoid any complications. And that way, anesthesia doesn't panic about, like you said, putting in a regional anesthetic. So, no, I mean, certainly if you're on actively anticoagulated, and you go into labor, I mean, the prophylactic dose has never been associated with an increased risk of bleeding. And we're all careful to make sure the bleeding has stopped before we close the patient up. If you're on a fully anticoagulated dose, like someone that's had a clot in pregnancy, and you suddenly go into labor, yeah, you're probably going to have a higher risk of bleeding. But that's a pretty rare circumstance. And again, we're going to do everything we need to control the bleeding. And there are now reversing agents for the heparins and the
Reverse.
low molecular weight heparin. So, I mean, all of those things are manageable.
Hi, doctors.
Yeah, whenever in hematology.
Yeah. 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 Hi, doctors. All of us.
All of
Yeah.
us.
All of us. Yeah.
All of us, yeah.
I know where you're going with that, man.
I have low positive lads. Do I need to do lit?
Fred,
So
Fred
again,
and I were discussing this before this show. Yeah. So Fred, let me just say, again, just to echo what we talked about earlier, no one needs to do anything. Is lit an option for someone with LADs? Yes, lit is an option for
yes,
someone with
absolutely.
LADs.
But I think again, let's go back to why do you know that you have low LEDs? Because people come and very frequently ask to do testing, but they've never failed anything. They've never been pregnant, never failed anything. They're just prophylactically. So in prevention of possibly, maybe one day, perhaps, possibly, maybe, they want to do all these things. Well, if that's the case, then probably you don't need to. But is lit an option of treatment for low LEDs? Absolutely, it
Yeah.
is.
Yeah. And arguably it's probably the best treatment of low LADs, right?
It is, but in places where they can't do lit, they do IVIG, which is a very
IVIG, yeah.
costly approach, but it also works in a very similar manner.
Yeah. But people can sell their organs on the black market and pay for their IVIG. Yeah.
Big question here. Get ready.
Oh, big question.
Big
Okay.
question,
All right.
IVF cycle was canceled due to an estrogen cyst,
Okay.
which was drained but is still 10 millimeters.
10 millimeters?
Yeah.
Okay.
Now I have a new 12 millimeter cyst on the other ovary.
That's called a follicle.
What was that, Fred?
That's called a follicle.
Okay. Possibly an endometrioma, and my estrogen is high again. Continued. So the cycle is canceled. Have low ovarian reserve and endometriosis, so avoiding BCP and estrase. Are there other options to prevent estrogen cysts, and would you just keep postponing until the next cycle? I actually don't know the answer.
Fred, you want to tackle that?
My answer is going to be very generic in the sense that I think that chart needs to be reviewed so we understand what's going on. And I was saying this a little bit sarcastically, saying it's a follicle, it's not a cyst. But I mean, if you have a low ovarian reserve, you have a new cyst that appears every month. Well, maybe you're recruiting a follicle early. Maybe that's producing estrogen. Maybe there's a lot of maybes. So I certainly wouldn't just keep postponing forever and ever, because you may be doing this for a long time. And I also think that if really there's a huge concern, you could probably take a very low dose of estrogen in the first few days of your cycle and see whether it actually delays the development of that quote unquote cyst or follicle, and that gives you an answer as to what it is. But it could be anything. It warrants probably looking at it and being able to look at the whole story.
Yeah, I agree completely. I mean, I remember one patient who was clinic shopping and had approached me years and years and years ago. And she was waiting for the perfect cycle. And she was already, I think, 43 or 44, if I remember correctly. And she kept saying, I'm waiting for my FSH to go down. I'm like, that's not going to happen anytime soon, like, or ever. And so I think people get stuck in this idea that everything has to be perfect before they start. And it needs to be appropriate. But if you're right, like if you're older, you're going to be recruiting follicles earlier because your FSH is so much higher. So it may just be that you need a different approach to things rather than waiting for the estrogen level to magically correct itself. So do you do estrogen priming? I mean, I very rarely do it, but is that something you guys use?
We do it for actually, it's funny, we do it for the older, quote unquote, and I shouldn't say older, but for patients above a certain age and patients who have a low ovarian reserve, simply because we don't want to have that one follicle that's ahead of everything else, which is pretty much what's described in that question. So I think in those patients, there's clearly an advantage to priming. But if you're 25, you have PCO, I'm not priming you.
Yeah. And we use a lot of Cysin and testosterone and DHEA, and I rarely get people that have one follicle that's way ahead of the others. So different version of priming. But I mean, I think there are indications for estrogen priming, and I think there's indications for the androgen primers. So yeah, I mean, I think that's a way around that. I'm not sure. I love the idea of draining estrogen producing cysts. I mean, that doesn't make a ton of sense to me, but yeah. A lot of questions. I don't think we have enough battery for a lot of questions.
We're living on the edge here.
We're on fumes.
Oh, here we go. Can you both?
Can we both? Yeah.
So I'm obviously
you're excluded. I'm sorry, buddy. Yeah, we still love you.
If there was, what is this for 3? So both is assumably 2, but
all?
3 all is
yeah.
just that's
yeah,
it.
Yeah.
2 and all.
Both and then everyone. Yeah.
Right. So could you all give your opinion on the intralipids in pregnancy?
Dr. T, I'll let you start.
Yeah.
It's a case-by-case situation is how I like to look at it. Bring me your files and your documents, I'll take a review, and then I'll give you my thoughts on it. I don't think it's for everyone, but again,
you've been hanging out with Rahi, I see.
A bit more.
Yeah. This guy could, sell you the shirt off your own back. So, I mean, yeah, we use intralipids right through the pregnancy in some cases. I don't have any trouble with intralipids in pregnancy. Fred, how about you?
I don't have a problem with intralipid in pregnancy. I think in most cases it's useless, not harmful, but useless. In most cases. There are some cases where, in fact, today was one of the days where I've actually told patients because of elevated natural killer cells that have responded very well to intralipid, and because of late miscarriages, I suggest we keep going. But generally speaking, depending on what the pathology is, so for example, if it's implantation failure, well, once there's implantation, you're pregnant. I usually stop and it doesn't yield miscarriages. So we try to target what the problem is. And again, it's not easy because it's always easier to say, well, get treated. And it's always easier to do more than less, because generally speaking, no one is going to blame you for doing more. But we really try, Chloe and I, we really try to limit what we do when we feel like it's not bringing anything more to the story. And we haven't had patients where we've gone back and said, oh my God, we should have continued intralipid.
Yeah.
So far, so good. Is it harmful? Absolutely not.
Yeah, I mean, what we found, we typically went to about 6 weeks, and then what we found was everyone was panicked about stopping it, because if they had had an adverse history before, whether it's justified or not, everyone thought it was the intralipids that was saving them. And because of that, they all just wanted to stay on it. So we said, like, spread it out far, every 6 weeks or something. And we tell everyone, like, you can pretty much stop whenever you want, but a lot of people just want to stay on it. So I say the same thing. It's harmless. We keep our prices fairly low, and so people are like comfortable doing it. But I agree. I mean, I don't think it's doing much after that first little while. So.
But the one thing that it's doing, and you have a very good point, is that it actually can provide some psychological well-being. And you know what? If taking yellow Smarties provides you with psychological well-being, no one's going to complain. Well, no, but intralipid is like lipids, right? So,
I
like
love that analogy. We're going to use that from now on. The yellow
ones, not the
Smarties.
blue
Yeah.
ones.
Yeah.
Not the blue
I'm a
ones.
green Smartie guy, but that's because my wife and my daughter have green eyes. So yeah, I like that analogy. That's good. Yeah. Almost 9, man.
We're going to make it.
We're going to make it. Yeah. One more question.
Okay.
And then we gotta allow poor Dr. Dzineku to attend to his family. But yeah.
Hey, doctor, my blood pressure was 149 over 90.
Okay.
Am I okay? She said it's normal, but high normal.
I mean, 149 over 90 is elevated. Anything over 140 or over 90, assuming you're pregnant, would be considered high. Technically, it has to be 6 hours apart. So we would want to recheck it. And often we're going to ask you about your symptoms. Do you have headache, right upper quadrant pain, visual disturbances, stuff like that? Anytime your pressure is elevated, it never hurts to get checked out. So there's always someone at obstetrical triage. And if you're concerned, you should be evaluated. But I mean, we don't necessarily pounce on every single patient that has an elevated pressure. Fred, what do you do when you see it in your obstetrical cases?
The one thing that's interesting about that question is that it brings about one thing, which is that Rahi, you and I, and Chloe to some extent, but are two of the few REIs who actually do active obstetrics.
Yeah.
So all the way up to deliveries and C-sections and everything else, and so that's interesting. We at Tripod, we follow our obstetrical patients, and then we in Ontario, we send them off to a collaborator of us, but I still do practice obstetrics. When we see, so we usually do exactly that. We ask all the clinical questions.
Yeah.
We'll usually have a tendency to do a pregnancy-induced hypertension workup just to be sure that it's not something that's starting. We will ask patients to keep an eye on their blood pressure at home, because sometimes it's just the fact that they're in the room, you walk in, you go boo, and then you take the blood pressure and they're scared. So we do that, and then we just, depending on what you see, you may have to do a growth ultrasound to make sure there's no growth retardation. There's many things, but I think the key element in what you said is go see your physician and bring up your symptoms and get checked, and make sure that there's nothing more that needs to be done.
Right. Yeah. Yeah. And, for safety and, of course, medical legal reasons, we can't tell you what to do on the show, but anytime you're concerned, you should go to obstetrical triage and be evaluated, because you can't take a risk. And we can't on a show like this tell people what to do with urgent or emergent situations, but I can tell you in a clinical setting, if you showed up and it was your first time with high blood pressure, you were asymptomatic, your urine had no protein in it, I'm not going to pounce on that and send you immediately to OB triage, but I would want you to recheck your pressures. And certainly if they were staying high, we would want you checked out, do the blood test, make sure there's no evidence of HELLP syndrome, HELLP. And so we would do the requisite testing to make sure you were safe. I think we're past 9, man. Dr. Dzineku, it has been probably years in the making to get you here, but I am very honored that you came. Thank you again for joining us. You're always welcome back. We would love to have you again. We're probably going to need to do a 5-hour-long show for the number of questions that we have. Tarek will send you a list of the remaining questions, and if you want to answer them on your own, feel free to do so on your Instagram or social media. And if anyone wants to contact Dr. Dzineku, Dr. Dzineku is at Tripod Fertility. They can go to tripod.com. Is that right? Is it tripod.com or tripodfertility.com?
Tripodfertility.com. In fact, we have a new website. We're quite happy with it. So yes, absolutely.
Awesome.
Tripodfertility.com.
He is available there, as well as his equally incredible wife, Chloe Romain. And again, thank you immensely for talking about Fertility Friends Foundation. Phenomenal foundation, doing great work. So all of you who watch the show, there's usually about 5,000 people that pop on and off of this show. So if everybody just gave $5, we'd actually have enough to, fulfill quite a lot of support there. So please give, please be generous, help Fertility Friends Foundation, because you're helping everybody around you. Thanks so much, Fred. Appreciate you being here, buddy.
Thank you for having me. It's been a pleasure. It's a great intro to this. I enjoyed it. I will definitely come back.
Awesome. We'll look forward to having you back, and we'll see
Dr. T, thank you.
My pleasure.
We'll see you next week on Fertility Fact or Fiction, everybody.